Hi, this is Jay Kumar with the North Carolina Healthcare Association. I just want to welcome you all to our webinar today. A few logistical points. If you have any questions, feel free to type them in the chat, and we'll be monitoring them and making sure our panelists receive them. And then we'll have time at the end where we'll unmute your lines and you can ask questions to the panelists directly at that point. So today we're going to talk about our diversion prevention toolkit, and we're very lucky we have Evan Frazier from Duke University Health System, Angela Livengood from Pender Memorial, and Anna Stein from the Division of Public Health with us to go through the work they did in developing that toolkit and how you and your health system can benefit from the components of it and how you can utilize it. This webinar will also be recorded, so you can revisit it at a later time or share it with your colleagues and be posted on the NCHA website. So at this point, I'm going to turn it over to Evan Frazier, who will get us started today, and we will go from there. Evan?
Thank you, Jay. Thank you all for attending this afternoon. To set the framework for our discussion and the webinar today, the North Carolina Healthcare Association established the Coalition for Model Opioid Practices in Health Systems back in 2016. One of the first items of business that we had as a coalition was to determine the direction that we were going to take, and thus we put together this document that established and outlined our goals, objectives, strategies, and tactics that we were going to focus on as a coalition. During the webinar today, we are going to focus down in the healthcare worker objective and the strategies that you see there. In addition, we're some recent items that have been in the news around a DEA settlement agreement with a major academic medical center that took place in the last couple of months, and these will be highlighted by the three asterisks that you see there, just quotes from that settlement agreement, and this will just emphasize what the DEA is expecting when they come into your facility and look at the controls that you have and the management that you have around controlled substances. So as an overview of the toolkit, like I mentioned, this was the work that we did through that coalition and the diversion focus that we had there. It is available on the North Carolina Healthcare Association's website, along with other great information about the work being done by this coalition. The toolkit provides information in each of these areas that you see there on the slide, and we'll go into more detail to visit the website. The information we'll provide during the webinar today is a high-level overview of what is detailed out in that toolkit. And then I just want to provide some acknowledgements to these organizations and individuals who helped put this together. It was a great collaborative effort between the nursing board, the medical board, the pharmacy boards, the DEA, the State Bureau of Investigation here in North Carolina, the Drug Control Unit, and all those other organizations that you see there, as well as many individuals that are not on as presenters for this webinar, but also did a tremendous amount of efforts in this. To pass it to Angela, who our and workforce wellness.
Thank you, Evan.
Angela, real quick before you get started, as you noted a couple slides ago, there was the diversion website, ncha.org/diversion. All of the contents of this webinar and the toolkit, you guys can all download from that website. So we had some questions of their handouts. Everything is live on the website now for you to download and follow along if you so choose, or you can look at it after. So I just want to make that point.
Thanks, Jay. Okay. With the healthcare worker diversion section, and there are 4 strategies presented in this section: prevention and workforce wellness, diversion program structure, monitoring and surveillance, and reporting. Evan, Anna, and I will present an overview of each of these sections in detail during our start here for now. go. Of any employee wellness program address increasing resiliency, promoting clinician wellness, and reducing burnout. The benefits of an employee wellness program include lowering staff absenteeism by 27%, decreasing healthcare costs, and reducing workers' compensation and disability claims by 32%. Additionally, poor employee health has been shown to adversely impact productivity with a reduction of 5 to 10% according to the CDC. The Toolkit's website has links to other documents detailing the return on investment for employee wellness programs. There is also information on value of investment and value of caring, which are two newer methods for assessing the effectiveness of these programs. The steps to develop a wellness program are to have an assessment of the current program provided by the hospital or health system. Then you can move to planning the goals, ideas, and strategies for the program needed by the facility. And then implement, put the plan in action. And finally, evaluate your program using employee feedback and adjust to better meet their needs. There are great resources on the website under the section for developing a program for large and small hospitals. A comprehensive program includes not only physical health, but also mental health. Healthcare workers are susceptible to compassion fatigue, made up of burnout and secondary traumatic stress. When experiencing burnout, our team members may feel exhausted and overwhelmed, like nothing they do will make the situation better. For some, the negative effects of this work can make them feel like the trauma experienced by the people they're caring for is actually happening to them or to the people they love. This is what secondary traumatic stress is. Apathy, isolation, bottled up emotions, and substance abuse are just a few of the symptoms associated with compassion fatigue. Additionally, employee volunteer programs are an excellent option to help promote workplace wellness. 9 out of 10 people who are involved in volunteer programs experience an emotional burst from their participation. The majority report lowered stress and endorse improved mood. And in fact, almost 90% of employers report a correlation between volunteer programs and increased employee engagement, which is important to all of us. So preventing diversion. Healthcare workers in particular are prone to work-related stress given the work environment that we practice in. When there's a shortage of time or any positive coping skill, such as exercise or health or relaxation, one coping mechanism that can be turned to is alcohol or drug abuse. Due to the easy access to controlled substances in our work environment, drug abuse among healthcare workers can lead to drug diversion from the workplace. Whoops, sorry guys. Jay, can you help get the arrows back? Thank you. Okay, sorry guys. Healthcare workers, again, are prone to diversion, and the easy access of controlled substances in our work environment places us at risk as well. The toolkit provides great detail about setting up a workplace wellness program. So anyone considering adopting a new employee wellness program should refer to the PDF available at the website There's an abundance of resources on where to start and how to develop a program. Now, if you already have a program, that's fine. You can use the toolkit as a benchmark to assess what you provide based on and compare it to other options available from other hospitals in our state. Now let's move to the second piece, which is diversion awareness education. Remember that identification of diversion in the healthcare workplace is often from reporting of suspicions or odd behavior from teammates and not necessarily detected by objective monitoring. And here, as Evan mentioned, in the $4.3 million settlement to establish these two items, the first of which is a diversion awareness education program during new employee orientation to highlight the potential for drug diversion in the workplace. The second educational component was an annual mandatory education designed to prevent drug diversion and reinforce the need for safe handling of controlled substances. Many people are surprised when they learn about how common workplace diversion can be and the signs associated with working with an impaired or diverting teammate. Common first reactions of coworkers are, "I would have never suspected him or her," or "she is such a good worker and so helpful, I just cannot believe it." All employees have to know how to report a concern and to have an option to do so anonymously. While it's preferred to have the name of the person reporting to facilitate any follow-up needed, many don't want to give their names, and we don't want this to be a reason for underreporting. Patients and coworkers, remember, their safety is fundamental to our work. Each hospital employee should have some level of diversion education. There are reports of controlled substances being found in hallways, stairwells, and bathrooms. All staff need to know what to do if they are the one who find those controlled substances. In addition to the general information needed for all staff, more detailed information should be provided to the staff who handle controlled substances, who are supervisors or providers, and finally security or hospital police. The education provided to each of these groups is tailored to their job duties within the controlled substance management process. For example, those who handle controlled substances should have information on how to handle those substances properly, including the need for witnessing, wasting, and returning. And remember, this is not just nursing. That would be pharmacy as well. For supervisors, they need information on what to do when you get a report of a suspected impaired teammate. What do you do? How do you proactively monitor for diversion? Our prescribers need to be able to identify who is doctor shopping and when is the appropriate time to use opioids or controlled substances within our pain management armamentarium, and also to have feedback and discussion about the appropriate prescribing habits. And finally, security and special police. These folks should know the policies of the organization, but also the laws around reporting and investigating instances of suspected diversion. The toolkit provides various examples of education that can be used as a framework. Information from several organizations, articles, and examples give you a great starting point. Again, customize these reports to fit your facility's needs. Evan will now discuss the next two components of the Healthcare Worker Diversion Toolkit.
Thank you, Angela. And so the next two components that we have here that we'll go into and start discussing are around how you would structure a diversion prevention program, as well as what type of monitoring or surveillance you should have as a minimum, as well as some other ones that you'd want to implement if your resources allow. So the diversion program structure, you can ask the question, where in the medication use process can diversion occur, or where does it occur? And really, it is anywhere within that medication use process, from the procurement, preparing, dispensing, prescribing, administration, wasting, returning. Any of those instances are subject to potential diversion. And so all of them should be set up so that you can have controls in place at each of those points of the medication use process. As we refer back to that DEA settlement, and these quotes that we have are from the most recent one, but they're not unique to that settlement. They are similar things that have happened and requirements that the DEA has for other settlements that are available on the internet if you were to search for those. But here they do require that we have those security controls and procedures in place to prevent waste from being diverted, was one that they called out. And another example that's not always thought about was the diversion of controlled substances through the return process, that an individual could alter or could tamper with an item to remove and replace the controlled substance with saline or water or something else, and then return that to the automated dispensing cabinet and do so in a way that it doesn't look like it had been tampered with. And so having the controls there to monitor for these type of activities is essential. So some questions that you may be thinking about when you consider your structure or implementing a program and where to start. Now, the first question, is your program adequate? Are the controls that you have in place currently for all those points along the medication use process? And then are the processes and procedures you have in place comprehensive enough to be able to identify potential diversion that may be taking place? And then are you doing enough? Are you monitoring the controls that you do have in place? And are you adhering to the policies and procedures that you have in place? If you don't have a program structure, where do you start? How do you get one set up? When you start something from scratch, it can feel very overwhelming. The saying that you need to eat the elephant one bite at a time, but then there's the question of which bite do you take out first? You bite out of the leg, the ear, or the trunk. And the toolkit is a great resource for helping you identify what those starting points can be for your organization. And then the last question, are you focusing on the right areas? Do you have the right monitoring in those right areas? We're all strapped for resources. We know that there's not an abundance of resources for all hospitals. And so knowing what your resources are you deploying those in the most effective way to monitor the areas that are the most critical? So to help answer those questions for your organization, as part of the toolkit, we do have a self-audit checklist. And actually, we have it divided up into two checklists for you. We do have some benchmarking data that is based on hospital bed size. So you can know how you compare with hospitals that are of similar size and what they have implemented versus what you may have implemented at your institution. The first checklist that we have provided is a simple yes or no. Do you have these things or do you not? Really looking at the DEA regulations and state regulations to ensure that you have them in place. And these are the more black or white items that you have. An example from the most recent settlement is needing to have the registration for your off-site locations. The DEA regulation states one general physical location per registration. And so do you have that in place, yes or no? And you can go through that checklist and answer those questions. And then the next one is more of a scale rating. It's very similar that you probably have seen for other self-audit checklists for other items, and you rate how frequently you're doing something or how much it's implemented. You have it implemented in some areas and not other areas, or is it fully implemented? And so looking through those recommendations that are on that checklist and seeing where your gaps are for your institution and your current program, or if you're trying to establish a program, what you need to focus on and what you can be looking at. What this also helps is looking at these other two items that were on that are on that checklist to make sure that you're doing it. So one thing that was called out in that recent settlement were discrepancies from the automated dispensing cabinets were not consistently supported by documentation to show that they were properly identified, investigated, and resolved. And do you have that in place? That's one of the items that's on that checklist to see if you have those processes in place to ensure that you have that documentation available. It also helps as you go through that checklist to share that with your hospital leadership and to review that through your committee, which we'll talk about in just a moment. One of the findings that was in that settlement is that the key personnel of the hospital did not sufficiently know about their own processes, their own procedures, and could not identify where those controlled substances were stored. And so going through this checklist and then using this to educate your hospital leadership of where your gaps are in meeting the requirements that you have to manage your controlled substances. So next we'll talk a little bit more about what type of surveillance and monitoring should you have in place. And here you can see a list of some ideas and things that have worked for me and have worked for some of my colleagues that I've talked with. And you start with medication safety rounds or controlled substance rounds or tracers. I think many of us are familiar with that tracer methodology and may already be doing some medication safety rounds or medication tracers to include looking at your controlled substance processes during those rounds that you're already doing or during those tracers. Or if you're not doing those, to look to see, is this something that we should do? That you would go to a nursing unit randomly, talk to the staff, ask questions, see if they understand what the policies are they following those policies, looking at documentation of the discrepancies, as we mentioned before, and then checking some transactions and following it. When was it removed from the dispensing cabinet or delivered from pharmacy? Was it documented as being administered, or was everything wasted that needed to be wasted, and things of that nature? Patient rounding can also be an important part of your controlled substance monitoring. Many institutions already implement this for their nursing colleagues, that they go around and they talk to all their patients. But asking them about their pain control, is there times of the day or days of the week that's been better or worse? And is there a pattern there that may be able to come out of that as you're looking at your potential diversion? Reviewing transaction reports, looking at who's accessing the controlled substances, and are they doing so appropriately and in following those procedures? Looking at any floor stock that you have and doing reconciliation with that floor stock, as well as your dispensing cabinets, and that should be done consistently every shift, especially with your pharmacy staff, who are the ones that are restocking those that floor stock and restocking those cabinets. Are they doing so properly, and does everything match up with what was expected? One of the items I put on here is the use of urine drug screens. And I put that on here particularly because of this quote, again, from that settlement, is that the DA asked that they start to look at randomly testing their employees for controlled substances in the urine. And this is something that, if you haven't had that discussion recently at your institution, would be worth at least having the discussion. And the DEA doesn't say, as to my knowledge, if you have to do it or if you don't have to do it, but at a minimum, it is worth a discussion to see if that would be something that would benefit your institution. And then finally, using any analytical software that you have available. It may be financially unreachable for some institutions, but at least it should be considered and looked at, and to see how feasible it is. Because there are some expensive items, but there are some more that are more affordable. And one of the items that was on that again was being able to perform some advanced transactional analysis. And so giving some of that thought when those resources allow. Next, I'd like to talk a little bit about the auditing that you do. So the surveillance and the monitoring, something that's done on a daily or weekly basis. But there should also be some audits that are performed as well, looking at each of those points in the supply chain, in the medication use process, so that you're doing those audits and that you're checking to make sure everything's followed. And this is especially important for areas that you may not have a lot of monitoring or surveillance, or maybe more challenging for that monitoring and surveillance. Those areas that can be overlooked are the skilled nursing facilities or long-term care facilities or the emergency medical services, as those areas do have a lot of controlled substance use, but can be overlooked at times for the monitoring and the diversion prevention efforts that you've implemented. Now, there is no magic recipe for all these areas and for how you prevent diversion everywhere, but at a minimum, you should check to make sure you have the right policies in place, and then you should review those to make sure that those policies are comprehensive enough that when you do your audits, to make sure that you're following those and that you're able to track and monitor all those various steps. And so in the toolkit, it does outline how diversion can occur in your hospital anytime during that entire process with the medication use process. It gives several different tips for how to monitor for that diversion and things that you should look at as a minimum, as well as things that you may add on if you're able to. Give you some benchmarking data and those checklists that you can use to do a gap analysis and to look at your current program. And it outlines those fundamental components of a good, robust diversion program. And so now I'd like to turn the time over to Anna, who will talk to us a little bit about the reporting requirements that are outlined within the toolkit.
Thanks, Evan. Okay, so when we brought together our diversion prevention work group, we realized that there was a lot of confusion among health systems about what reporting is actually required when diversion is discovered in a hospital setting. And there's good reason for that confusion. It's because all of these requirements, no one sat down at one time and figured out what all the requirements are. It's very ad hoc. Every agency came up with its own requirement, and there's not a lot of rhyme or reason, in my opinion. And so we thought that it would be very useful for our group to sit down with various regulatory agencies and law enforcement agencies and find out what the actual legal requirements were, and set those out very clearly in this reporting document that's online on the toolkit, and then also to point out what is not legally required, but what might make sense for your health system to report voluntarily. So, and then there's a very handy checklist that I'll cover at the end of my presentation that summarizes all of the reporting requirements. So what we discovered is that there are really only 3 reporting requirements that apply across the board for any case of diversion. And so those would be reporting to the DEA, the Drug Enforcement Administration, to the North Carolina Board of Pharmacy, and to the North Carolina Drug Control Unit. So I'll cover all of those. So you're probably familiar with the DEA Form 106. So what we learned from the DEA is that, yes, they have to be notified of any theft. So any theft, no matter how big or small, or any significant loss within 1 business day of discovery. And so you don't have to file that Form 106 within 1 day, because there's more information on that than you might have. It's going to take time to investigate that theft or loss and fill out the form, and that's okay. But you do just need to immediately notify the DEA that you've had that theft or significant loss. And we have an email in our toolkit of a person at the field office in North Carolina that you can just send a quick email to them and say, just want to let you know we've experienced this stuff or this significant loss, and we will be investigating it and submitting our Form 106 when we have the information that we need. And I also wanted to just make a quick note after Evan's presentation about diversion protocols, detection protocols, that I also had a conversation with the DEA here in North Carolina where they said, if you have any questions about your diversion detection processes or anything about your DEA registration, feel free to call them, and they will not penalize you if you've been doing something wrong. So you don't have to worry that when you call, you're going to reveal that you haven't had a system set up the way it's supposed to be set up or that you've not been doing things properly. They said they're not in the business of going and retroactively penalizing you. They will be happy that you're reaching out to try to figure out the right way to do things now. So it's more like if they get notified that you're doing something wrong and they go and investigate, yes, you could get in trouble. But if you are proactively reaching out to them to try to figure out how to operate better, you are not going to get in trouble with the DEA, is what they told me. So, of course, there's some factors to consider when determining if the loss is significant, and I won't read all those out. Those are all in the toolkit. I know that's not always an easy call. The DEA does say err on the side of reporting if you're not sure if a loss is significant. So you also have to report to the North Carolina Board of Pharmacy, drugs, drug theft or loss within 10 days. You can no longer send in your DEA Form 106 to meet this requirement the way you used to be able to. You have to file a particular drug disaster and loss report online, and the toolkit gives very detailed instructions on how to do this and what tabs you should click on the Board of Pharmacy website to find this form. Then there's the drug control unit. That's the third mandatory reporting. So you know that every year you have to register with the drug control unit to dispense controlled substances. And then along with that registration, there is an annual disclosure of loss, diversion, or destruction of controlled substances form that you have to submit every year. So there are a couple other instances where you might be legally required to report an instance of diversion, and it's all going to have to do with what the licensure of the person that did the diverting is. So it all depends on their role in the hospital as to whether it has to be reported. So for physicians, if a hospital takes an action on their privileges, that does have to be reported to the medical board within 30 days of that action being taken on their privileges. But other than that requirement, there is no actual legal requirement that folks who are physicians or PAs or other categories that are regulated by the medical board be reported to the medical board. They do want you to report to the medical board if you find instances of diversion by these folks, but it's not legally required. Now, with nurses, on the other hand, it is legally required, and it's legally required of anyone. The statute's very broad. It says any person with reasonable cause to suspect misconduct shall report to the Board of Nursing, and they have an online complaint form for that reporting. So that does have to be reported by law to the Board of Nursing. So then we get back to some more voluntary reporting. So for pharmacists and EMS, these folks would like to be reported to. If someone in those roles is diverting, the Board of Pharmacy would like to hear about that. The Office of Emergency Medical Services would like to hear about it. But again, there is no statute requiring that reporting. So for unlicensed staff, there is a legal requirement for reporting. So this is any unlicensed staff who have direct access to patients or their property. So nurse aides or maintenance, security, transport, nutrition would all fall in this category. And so there is a legal requirement to report to the Division of Health Service Regulation within 24 hours in writing after becoming aware of the allegation that this person has engaged in diversion. And then there has to be a follow-up investigation reported within 5 days. There is a detailed description of the reporting that's required in the toolkit to the Division of Health Service Regulation. And another thing that I think is interesting and bears stating is that there is no legal requirement to report to law enforcement in this state. The SBI would like to be reported to, and they've said that they can actually provide very helpful assistance in investigating cases of diversion, and they would like to be, let them know sooner rather than later so they can actually be of assistance. The regulatory board said the same thing: medical, nursing, pharmacy. Let them know sooner rather than later, and they can help you do that investigation. And you may also wish to report to, obviously, your health system police or your local law enforcement. So there are some additional agencies you could report to. So the FDA for instances involving tampering, the Office of Inspector General for HHS has a hotline for fraud. And then, importantly, for diversion of injectable medications that could cause communicable disease spread, the Division of Public Health has a Healthcare-Associated Infections and Resistant Pathogens Patient Safety Program. That's really a mouthful, but they are able to assist with any kind of assessment of whether your patients may have been exposed, and then also help with communications to patients about what their risk might have been. And so they stand ready to help health systems. So there is an FAQ section I wanted to point out in regard to employee references. As an employer, North Carolina law does provide protection for liability if you give truthful statements about letting an employee go for diversion. And also, just to let you know that under HIPAA, you are able to share HIPAA-protected information with law enforcement or professional regulatory boards as they investigate cases of diversion. And here is that summary of diversion reporting requirements for North Carolina health systems. That's kind of a cheat sheet that you can refer to in determining what the laws are for reporting. And now I'm going to turn it over back to Evan to talk about examples, in particular health systems in North Carolina, of diversion prevention programs.
Thank you, Anna. So I'd like to start to talk a little bit about what we've done here at Duke University Health System, and then Angela will talk a little that needs to be done. It's a committee that has a chair which has the responsibility of the controlled substance diversion prevention for the organization, and then it is a multidisciplinary committee that has that oversight. And having that representation from multiple departments is vital to the overall success of the program. As we discussed previously, diversion can happen at any point in the medication use process. And it can be detected through various methods, and so you need that multidisciplinary perspective so you can be sure your program is robust. One that may not readily come to mind when you're putting your program together is the infection prevention that you see there at the end. But that is definitely an important part. As we were just mentioned, there is an infection risk when you have IV medications that are being diverted, and there's cases that you can see from the CDC where that has occurred. In addition to that, there may be instances where the diversion is first uncovered because of an infectious disease cluster that occurs at your institution, and the infection prevention representation on your oversight committee will be able to help you as you investigate those items. So with our committee here at Duke University Health System, we meet monthly. Our committee, as we meet, we discuss any diversion events that may have occurred or any concerns that people have about gaps that we may need to address or changes that we may need to make. We have a dashboard that we review every month with the various metrics that we put on there, as well as any reports that have come to light. We also look at best practices. We review these reports that come from the DEA that we've mentioned a few times today, as well as other best practices from organizations throughout the country that provide that information and help us to learn what other organizations are doing so that we can learn from others and make our program more robust. In addition to that, this group's also tasked with developing and maintaining the education material for staff, as that is a vitally important part of any diversion prevention program. As Angela mentioned, most cases of diversion are reported, so it's something that a coworker identifies or has a concern about, and it gets reported to this committee or through whichever channels you determine, rather than something that's been identified by the monitoring and surveillance that you have in place. It's important to have both pieces there, but I think this education is a vital piece of any diversion prevention program. And so now I'll go ahead and turn it over to Angela to talk a little bit more about what they've done at her institution.
Okay. Well, I practice at Pender Memorial Hospital. I'm the pharmacist manager, and we are a critical access hospital. So we are small in size, but no less susceptible to controlled substance diversion than a larger facility. Day to day, our prospective diversion program is led by the pharmacy, but our nursing leaders are ready, willing, and able to help us out if the need arises. So daily, we review controlled substances and their activities for the previous 24 hours, and much of this is done by my lead pharmacy technician, and she is wonderful at being detailed-oriented and following through on investigations. We also pull information that we submit to an independent consultant that we have contracted with, and these reports that we send them consist of instances of whole dose wasting, unresolvable discrepancies, patterns of usage or administrations from the automatic dispensing system that we use. And we submit all of this to this independent consultant, and then they generate for us what's referred to as a hot list, or a list of employees that we should review retrospectively to see why they rank so high. And then this independent consultant also makes a site visit twice a year to Pender to basically review and audit our whole controlled substance management program. It's the same person that comes each time, so she's well learned about our process as well as what is required from the DEA in the state of North Carolina. And she investigates all of our records, all documentations, and the processes that we have in place with our controlled substance management system, and generates a report that then is shared with not only me, but the president of our hospital, the chief nursing executive, and our network director of pharmacy. Pender is also part of the New Hanover Regional Medical Center network, and we as a network are working to make our diversion program more solid and well-rounded. And we, as a growing system, are trying to figure out how to pull in all of the sites that are now under our umbrella. So we are organizing a network-wide drug diversion response team that is tentatively called the DDRT. And we're also developing a drug diversion policy that incorporates a risk assessment tool based on the North Carolina Board of Nursing assessment tool to help us better objectively direct our actions when someone is suspected of diversion. It combines both what is identified by the Board of Nursing and their tool, along with the monthly reports that are generated centrally in the pharmacy. Again, these are all works in progress, but it just goes to show that we are all on different places in the path of how to have a great diversion prevention program, and it's not something that we need to be afraid to share. We can ask questions. Evan has been a wonderful resource for us, and it just goes to show this is a partnership. Now I'm going to turn this over to Jay so he can talk more about what NCHA is going to do from this point forward.
Great, thank you so much. So here at NCHA, we've been working on socializing this toolkit, and really from this point on, as your systems look to audit or develop their own diversion programs, we will be stepping in, hopefully, to provide some technical assistance to you throughout the next coming year. So look for, over the next 6 months, really starting in January, some meetings that will be taking place across the state to really look into how you can operationalize this. You can also reach out directly to me at NCHA to help schedule that and work one-on-one with your system on how we can do that and make sure that it becomes kind of part of your processes. And then throughout the entire life cycle of this moving forward, knowing that this is a complicated and complex issue that has a lot of questions, and knowing that you have a resource at NCHA that you can turn to and directly ask, and we will be able to connect you with the right answers and the right people through this work. I think Anna had really mentioned it. Stuck out to me was there's a person who you can email right away, and that's available in the toolkit. And the toolkit's really designed to be plug and play for your health system. And so downloading the parts that work for you and implementing it, we've tried to make that as easy as possible for you. At this point, I want to save our last few minutes for questions. And Evan, Angela, and Anna, the first question that we received during the call was, do these regulating opioids or controlled substances and for internal sedation in their office? And so that's the first question. How does this affect dental practices in their diversion policies? And then as others have questions, you can raise your hand and we can unmute you, and you'll be able to ask the group.
That's a really good question. And so I haven't thought about dental practices, but I'm going to sit here and think about it right now. So I know DEA regulations require you to register if you're prescribing and dispensing, if you're keeping controlled substances on site that are capable of being lost or stolen, then you do have that DEA registration, and so you would be required to report to the DEA if you had a loss or theft. The North Carolina Board of Pharmacy requirement is for hospital pharmacists. So since there's not a pharmacist on site at a dental office, I don't see how you would be required to report that, but that could also be a question for the Board of Pharmacy. And then as far as the drug control unit, reporting to the drug control unit, you are also going to be having to register with them as a dispenser of controlled substances, just like a hospital would. And so you would have to be filing that report to the drug control unit. So that would be my answer, in that, yes, to the extent that you are having to, register as someone who holds controlled substances on your site with the DEA or the North Carolina Drug Control Unit, you are going to be having to file reports to those agencies if you have a loss or a theft. Does that resonate with our other panelists?
Yes, Anna, I would agree with that. You do still have those DEA regulations. I'm not as familiar with if there's any caveats for dentists, but there is still the registration requirements and the others that you outlined.
I do know globally there's more of an effort being made, I think, with the opioid crisis in trying to standardize and bring multiple specialties in alignment. So from pharmacists to dentists to veterinarians even, there is a movement really to get all of the folks who are handling these controlled substances operating in a more streamlined way. Another question we got is there any data that supports the effectiveness of random drug testing? I'm assuming you mean urine drug testing, and then do these routinely identify or curtail diversion?
So I am not aware of any data that would support the use of random urine drug screening. There are pros and cons to both, and we do list some of those out in the toolkit. I do know just from colleagues that I have throughout the country that there have been times where they've been able to identify diversion, and that was a piece of it. It wasn't the only thing, but it was a screen that they did. But I am not aware of any detailed data or numbers to support one way or the other if you should do that. I do think it's worth a discussion with your institution to see if it's something that would be beneficial, but I don't have the data.
Any other questions for our panelists? All right, I'm seeing none. So at this point, like I said, please feel free to go through the materials that are on the website, and if you have questions, please reach out. My contact information is on there, and we'll be able to hopefully provide you with assistance and help you really think through a process that works for your system and your clinic and your hospital, because while the toolkits are designed to be plug and play, we know that there'll need to be some modifications for each of the systems to make it work on their behalf. Oh, we just got one more question in. So what information do people generally pull from their advanced analytical software and follow up on? For example, if surveillance data indicates a high user of a certain controlled substance, is an audit done on that specific drug?
So when you look at the various different types of software that's available out there, but are looking at patterns of usage, patterns of wasting medications, as Angela mentioned, the whole dose wasting. Also, each dispensing cabinet may function differently. Things such as what we refer to as null transactions. So it tracks all the transactions that occur and is looking for those patterns of who's doing more than expected in each of those various transactions. And then, yes, at least from what I do here and what I know others to do, if an individual does come up through that software as a person of concern, then we do look into all the details of all those transactions and look at is it being a potential practice, that they're not following procedures like they should be, and they're not doing things that they need to be doing, and we need to re-educate and coach that individual.
All right, well, thank you all so much for participating. Again, feel free to reach out with questions or thoughts you have moving forward. And if you have success stories or implementation efforts, we'd love to hear about them from you so that you can help us continue to make this tool better. With that, we will end the recording, and everyone have a wonderful day.